Doctor. All right. I'm Dr. Vincent Larray. I'm in the Division of Infectious Diseases and the Department of Biostatistics and Epidemiology at the Perelman School of Medicine. My area of interest is in acute and chronic liver diseases, particularly chronic viral hepatitis, especially in persons co-infected with HIV infection. How's that?
Great. So the next question is, so you study co-infected individuals. Talk to us just briefly a little bit about rates and risks in that population. Is it common for people to have it, maybe sprinkled with some percentages, things like that?
Okay. So co-infection with chronic viral hepatitis, particularly hepatitis C, is common in the setting of HIV due to shared routes of transmission. And approximately 20 to 30% of HIV-infected patients are co-infected with chronic hepatitis C.
You okay on sound, the rolling cart?
I just heard a rolling cart, but are you good?
That covers it, yeah.
You want me to do it again?
No,
No,
it's
we're
fine, it's
good.
good.
Okay.
Just turn your shoulder.
Sorry.
Yeah, that's fine. Yep, I'm rolling.
Okay. So the next question is, just talk to me a little bit about what you were looking at. What was the purpose of this study?
So we were interested in determining whether HIV hepatitis C co-infected patients who receive antiretroviral therapy have similar incidence rates of end-stage liver disease, particularly hepatic decompensation, hepatocellular carcinoma, and liver-related deaths compared to those with chronic hepatitis C alone.
What's a hepatic decomposition? What does that mean?
Hepatic decompensation is liver failure that occurs in the setting of chronic liver disease. And it's characterized by the presence of clinical complications of cirrhosis, particularly ascites, spontaneous bacterial peritonitis, esophageal variceal hemorrhage, and hepatic encephalopathy.
Okay, now the next question is sort of what did you do to find this out? Talk to me about the design. I know it was a retrospective study. Talk to me about what you did for that.
Okay, so to answer our study objectives, we conducted a retrospective cohort study using data from the Veterans Aging Cohort Study. We identified new HIV hepatitis C co-infected patients. Who newly initiated antiretroviral therapy, and then compared them to chronic hepatitis C mono-infected patients. After a baseline period of follow-up, we then followed these patients longitudinally for a median of anywhere from 7 for the HIV hepatitis C co-infected patients to 10 years for the hepatitis C mono-infected patients to find the development of incident hepatic decompensation, hepatocellular carcinoma, or death due to liver disease.
My next question is, so what's unique about this study? I thought I read in there that it was the largest study to date looking at this population. Can you elaborate on that and maybe just start out by saying, this is the largest study to date, et cetera?
So there have actually been very few studies that have evaluated clinical outcomes of chronic viral hepatitis, particularly in HIV hepatitis C co-infected patients. And this is one of the largest studies to date that have longitudinally followed both co-infected patients on antiretroviral therapy to those with chronic hepatitis C alone. And one of the unique aspects of this study was that we identified a subgroup of co-infected patients on antiretroviral therapy who had HIV RNA suppression. And we compared those patients who maintained HIV suppression below 1,000 copies or below 400 copies per mil throughout their follow-up to those with hepatitis C alone, and compared rates of hepatic decompensation.
And then what specifically did you find? Because I know there was a couple points in there that the results.
So our study found that antiretroviral treated HIV hepatitis C co-infected patients had significantly higher rates of hepatic decompensation compared to those with hepatitis C alone. And where we conducted sub-analyses where we compared only the co-infected patients who maintained viral HIV RNA suppression throughout their follow-up to the hepatitis C only group, these patients still had a 60% higher rate of hepatic decompensation compared to those with hepatitis C alone.
can you do that again, just
Yes.
because you had just a little stumble?
Okay.
Just pick it up with when you compare it with the co-infected versus those just with hepatitis C. When
Okay.
you found a higher incidence of the, I can't remember
Okay.
what you said.
So our results found that overall co-infected Our results found that antiretroviral treated co-infected patients had an 80% higher rate of hepatic decompensation compared to those with hepatitis C alone. And when we conducted subgroup analyses where we only compared the subgroup of co-infected patients who had HIV RNA suppression below 1,000 copies per mil on all viral load measurements throughout their follow-up to the hepatitis C only group, the co-infected cohort still had a 60% higher rate of hepatic decompensation compared to those with hepatitis C alone.
That was great. I don't know how you remember all this stuff. It's amazing.
Is that right?
Yeah, that was great.
Yeah.
So what was surprising here when you're looking at all the data? What popped out at you? What was your
In addition, in a separate subgroup analysis, when we restricted both the co-infected and hepatitis C monoinfected patients to only those who had minimal or no hepatic fibrosis at baseline, we still observed that the antiretroviral treated co-infected patients had a significantly higher rate of hepatic decompensation compared to hepatitis C monoinfected patients. Okay. You asked me something else too.
Yeah, so after you went through the findings, I said, what was surprising about these results?
Yeah.
Sort of and also think about what do we know now that we didn't know before?
A major question that many clinicians had was whether initiating antiretroviral therapy in HIV hepatitis C co-infected patients made those patients like hepatitis C monoinfected patients in regards to their incidence rates of hepatic decompensation and other end-stage liver disease outcomes. And what was unique and what we found with regards to this study is that despite antiretroviral therapy, and in particular effective antiretroviral therapy, co-infected patients still had higher rates of hepatic decompensation compared to those with hepatitis C only. In a separate analysis, exclusively among co-infected patients, we examined risk factors for hepatic decompensation, particularly potentially modifiable risk factors in co-infected patients on antiretroviral therapy. And we observed that type 2 diabetes, non-black race, and low hemoglobin had significantly higher rates of hepatic decompensation. No, that's not going to do that well. In a separate subgroup analysis exclusively among co-infected patients, we evaluated risk factors for hepatic decompensation. And we found that diabetes mellitus, non-black race, and severe anemia were strongly associated with hepatic decompensation. Of note, we evaluated whether high versus low hepatitis C viral loads were also associated with hepatic decompensation in an exploratory analysis. And we found no association. And many patients commonly are concerned that a high viral load will lead to a quicker
Pick it up with many patients.
Many patients are concerned that high hepatitis C viral loads could hasten their progression to end-stage liver disease. And our results show that that is not the case. I don't know if that's all
That's
right.
important, though.
Do we have any idea why? I mean, what are your thoughts?
I don't think that there is a good reason that we know why the hepatitis C viral load does not predict end-stage liver disease. Yeah, I don't think that we really know that answer.
Okay.
So I think our study has important potential clinical implications. Certainly finding that there is a slight decrease in rates of liver decompensation for co-infected patients who achieve HIV RNA suppression really emphasizes the importance to both clinicians and patients that co-infected patients really need to achieve a suppressed HIV viral load to slow progression to hepatic decompensation. I think in addition, given that we found that co-infected patients have higher rates of hepatic decompensation despite effective antiretroviral therapy, I think both providers and clinicians really need to be open to initiating hepatitis C treatment to achieve viral cure and hopefully prevent progression to end-stage liver disease. And we're living in an era where there are so many new direct-acting antiviral drugs that have comparable success rates in co-infected patients that initiating these therapies at this point in time is feasible. And then lastly, given that we found that there are some modifiable risk factors such as severe anemia or diabetes that could be amenable to therapy, having providers address these modifiable risk factors will be also important in preventing progression to hepatic decompensation.
We were talking about what are the unanswered questions?
So where our group goes from here is we've been very interested in trying to determine what combination of clinical variables and laboratory variables can be used to predict future hepatic decompensation, to allow a provider to be able to determine what is the likelihood of that co-infected patient to go on to hepatic decompensation and to determine the need and urgency of antiviral therapy, particularly when we're living in an era when there are so many new antivirals that are on the horizon but which are taking time to be tested in co-infected patients. Prioritizing the urgency of antiviral therapy with predictive models that could utilize both laboratory and clinical variables will be really helpful for patients.
All right, is there anything else, just taking a step back from the study that you think that we didn't ask or that we missed that you want to include?
I think that's everything.
I have a question in this.
Yeah. Okay. So co-infection with chronic hepatitis C often occurs concurrently due to shared routes of transmission, particularly injection drug use, unprotected sex, intranasal cocaine use. We've been seeing a rise of acute hepatitis C in HIV-infected patients over the last several years due to unsafe sexual practices, particularly among men who have sex with men. I don't know, how was that?
That was good. Was there anything else in addition to the two men having sex? Was there
No, it was that you could get them together, the two men have sex. And then actually the last part where you're talking about, what you think that we should be studying. I mean, I don't know if you want to go into details that some people want to study, putting you on drugs for hep C first and then ART or vice versa. But I think that's sort of interesting, what you touched on there.
Yeah, given the advances that have been made in direct-acting antiviral drugs for chronic hepatitis C infection, that HIV hepatitis C co-infected patients now have sustained virologic response rates, cure rates, that are similar to those with hepatitis C mono-infected patients. And so really, for patients who are co-infected with chronic hepatitis C, given that these patients we've observed have higher rates of hepatic decompensation, now is the time to consider antiviral treatment. Okay, so to summarize, our study found that antiretroviral treated co-infected patients had higher rates of hepatic decompensation compared to chronic hepatitis C mono-infected patients. And despite effective antiretroviral and despite effective HIV suppression with antiretroviral therapy, co-infected patients continued to have higher rates of liver decompensation compared to those with hepatitis C alone. In addition, we found that non-black race, severe anemia, a hemoglobin less than 10, advanced baseline hepatic fibrosis, and type 2 diabetes were significant determinants of hepatic decompensation. I think these data would suggest that all co-infected patients should be considered for antiviral treatment for chronic hepatitis C, and both patients and providers should consider addressing modifiable risk factors such as controlling their diabetes, treating hepatitis B, avoiding alcohol, and avoiding potential liver toxic agents like acetaminophen to slow progression to hepatic decompensation and end-stage liver disease.